Welcome to this comprehensive guide on pharmacology. Today, we explore the cornerstone of antibiotic therapy, the penicillins, a class that changed medicine forever. Understanding antibiotics is essential for clinical practice. We will cover their history, how they function at a molecular level, and how we classify them today. Our journey begins in 1928. Alexander Fleming returned to his laboratory to find that a mold called Penicillium notatum had accidentally killed his Staphylococcus bacteria. This serendipitous event led to the first miracle drug. By World War II, penicillin was being mass-produced, saving countless lives on the front lines. But how does it actually kill bacteria? To understand this, we must look at the bacterial cell wall, a structure humans simply do not have. Penicillins are beta-lactam antibiotics. They work by inhibiting the synthesis of peptidoglycan, which is the structural backbone of the bacterial cell wall. Specifically, they bind to penicillin-binding proteins, or PBPs. These are enzymes that catalyze the final cross-linking step in wall formation. When the cell wall cannot cross-link, it becomes weak. Internal osmotic pressure then causes the bacterium to swell and eventually burst, a process called lysis. Because they kill the bacteria rather than just inhibiting growth, penicillins are classified as bactericidal agents. This makes them highly effective in many infections. Now, let's look at classification. We categorize penicillins into four main groups based on their chemical modifications and their spectrum of activity. Group 1 is the natural penicillin, like penicillin G and penicillin V. These are excellent for gram-positive organisms and some gram-negative cocci. However, natural penicillins are susceptible to beta. These are enzymes produced by bacteria that chew up the antibiotic before it can work. Those Bettis scientists created antistaphylococcal penicillins like nafcillin and oxycillin. They have a bulky side chain that physically blocks beta. Next are the aminopenicillins such as amoxicillin and these have an improved ability to penetrate the outer membrane of gram-negative bacteria. Amoxicillin is one of the most commonly prescribed oral antibiotics for respiratory infections, ear infections, and even some skin conditions. To broaden their use, we often combine them with beta. This combination is known as augmentin. Finally, we have extended spectrum penicillins like piperacillin. These are heavy hitters used in hospitals against tough pathogens like Pseudomonas. Piperacillin is almost always paired with tazeb. Together, they provide broad coverage for serious multi-drug resistant infections in critically ill patients. While penicillins are generally safe, we must watch for adverse effects. Hypersensitivity reactions are the most significant concern for clinicians. About 10% of patients report a penicillin allergy. These can range from a mild skin rash to severe, life-threatening anaphylaxis. Other side effects can include gastrointestinal upset, like diarrhea, and in very high doses, some penicillins can even cause neurotoxicity or seizures. In the modern era, the biggest threat to the efficacy of penicillins is the rise of antibiotic resistance through overuse and misuse. Clinicians must practice antibiotic stewardship. This means choosing the right drug at the right dose, for the right duration, and only when necessary. By understanding the pharmacology of penicillins, you can ensure these life-saving medicines remain effective for future generations of patients. We have covered discovery, mechanism, and classification. Master these concepts, and you will have a solid foundation in infectious disease pharmacology. Thank you for joining this educational deep dive into penicillin. Stay curious and continue your journey into the fascinating world of pharmacology.